All right, why don't we get started? One of the complications of acid reflux disease is a disorder called Barrett's esophagus, which I suspect many of you have heard about. This is something that is a potential problem that may or may not be as significant as is led to be believed in many circumstances. To help understand what it is, how we find it, what we do about it, what the options are, and what the risks are, Raman Muthusamy is going to speak. Raman is Associate Professor of Clinical Medicine, is the Director of Interventional and Advanced Endoscopy here at UCLA and within the Esophageal Disorders program. And you're going to be oohed and wowed by some of the slides that he shows you. So, Raman.
Okay. Everybody likes videos, so we'll show you some videos here. So how many of you, just as a show of hands, either have Barrett's or have a relative with Barrett's or someone close to you? Okay, so maybe a third or so of the room here. So I'm going to talk to you about Barrett's and sort of some misconceptions and try to maybe give you a better understanding and kind of go over what I go over with my patients when I see them in the office. So we're going to talk about what it is, how we diagnose it, what does it make you at risk for? How do we treat it? And what are the options? Who needs to be treated? And then we'll sort of wrap up with some summary and conclusions. Okay, so what is Barrett's? Well, it turns out the definition varies on the part of the world you're in. They actually have a different definition in parts of Europe than they do in the United States. But basically, as Dr. Roth showed you earlier, you have the stomach, you have the lining of the stomach. Sometimes you have a hiatal hernia where a little of the stomach goes up and the stomach folds sort of come to an end where my arrow is sort of pointing there. And then you have this transition between sort of the skin-like lining of your esophagus and more of the intestinal lining or columnar lining that you often see in the rest of the GI tract, okay? And so when this sort of line sort of gets moved up, instead of being sort of right at the junction of the tubular esophagus, but where you see sort of this creep of this sort of columnar lining going up the esophagus here, that is Barrett's esophagus here, okay? So this is the region of Barrett's in this patient here, and then this is a hiatal hernia that you see that's down below that. But Barrett's is not a diagnosis that you make endoscopically. You can suspect it, but you must make the diagnosis based on what you see under the microscope. So your doctor can suspect you have Barrett's, but until they get the tissue back, they don't know that you have Barrett's. So a lot of times I'll tell my patients, well, I saw some stuff, it might look like Barrett's, but I'm going to have to wait and see. And so it's really the histology that you absolutely have to need, and that's something that's a U.S. definition. Now in Europe, in certain parts, they think that the endoscope may be sufficient. Okay, and this is particularly, there's a certain type of cell that they're looking for. It's called a goblet cell or intestinal metaplasia. That's the specific thing that the pathologist is looking for. So again, when I'm scoping somebody, I'm going to take a look here and I'm going to sort of see this sort of what we call like a salmon-colored mucosa here. You see this sort of darker pink tissue here. This is the way the stomach looks, but the esophagus should sort of have this lighter sort of area up here. And so when you see the creep of this tissue sort of up into the tubular esophagus, that length is called, Barrett's esophagus. And again, this is a glandular sort of tissue, and you can see it sort of is forming glands that almost look like some housing subdivision or something here when you look at this here. But you can see sort of the glandular architecture when you look at it under magnification. Okay, so who is this guy Barrett? Well, he's actually a thoracic surgeon, Mr. Norman Barrett, and in England they call the surgeons misters, so they don't call them doctors. So originally it's believed that he felt that maybe this was a condition associated with a short esophagus, and he probably thought that because we know that hiatal hernia, as discussed earlier, can increase your risk for developing reflux disease. And many of these people do have hiatal hernias, and so a lot of their stomach is in their chest, and so he probably thought their esophagus was short. And he also sort of realized that this columnar lining is probably what's causing this change in the color that was associated with what he was seeing. So how common is this? Well, if you want an easy number to take away, it may be as high as around 1%. The studies, always vary in numbers a little bit, but it's anywhere between about 0.5% to 1.5%, which means in a country of 300 million people, you're talking, somewhere in the range of a couple of million people probably that have this. In terms of select populations, there have been studies that looked at people who were undergoing endoscopy for heartburn symptoms and found that anywhere between 5 and 20% would have findings of consistent with Barrett's. One study of people who are particularly high risk, which are older white males that were seen at a VA population in Northern California. So they took these folks when they were coming in for their colon cancer screening, either a sigmoidoscopy and colonoscopy, and said, do you mind if we take a look from above? Many of these people didn't really have symptoms. In fact, all of them really didn't have symptoms, but they found that up to 25% of them had Barrett's. So, the frequency of this, is probably pretty significant, and particularly in certain groups. So why do we care? Well, it's abnormal tissue, and it increases the risk for development of a certain type of cancer between 8 and 40-fold. But before you get too concerned about that, if I told you your risk of winning the lottery are 8-fold higher today, don't go out spending the money, right? You're certainly not a sure thing, because it's still quite unlikely that you're going to get cancer. So, but it does increase the risk. And we'll talk about the magnitude of that risk in a moment. So patients with Barrett's, of course, tend to stress about their Barrett's. They get anxiety, they may have reduced quality of life. And in some cases, obviously, with the whole issue of pre-existing conditions and so forth, I've had on some occasions even patients cite some insurance problems. So how do you diagnose it? Well, I've kind of given you a hint. Endoscopy is sort of how you take a look and suspect it. But again, you have to have the biopsies, and you have to see this intestinal metaplasia where you see these sort of dark cells that stain for mucin here, and these are sort of the goblet cells that we talk about, and these are the cells that sort of confirm the diagnosis under the microscope. Okay, so it's a combination of both. To help us sort of visually diagnose it, we have fancy scopes. So we kind of have our old sort of scopes on the right, and then you can see, of course, like your TVs have gotten better. Our scopes have gotten better too, so now you sort of get more clear images here. You can see sort of a better contrast between sort of this darker tissue and this lighter tissue. And again, this is the region of the Barrett's, the darker sort of pink area. We used to use stains a lot. There were certain stains that would make the Barrett's area turn blue or turn the normal esophagus sort of brown. But those are sort of messy, and it was time-consuming, and frankly, it was quite variable based on how long you held the stain for and so forth. And in general, it was hard to reproduce between different doctors, and so that's sort of fallen out of favor. Now we really have, with the quality of our scopes, with the high definition, the magnification, zoom features, and some optical filtering techniques we have, that's usually enough. We don't need to use stains. So Barrett's, one of the things, if you have Barrett's, you should sort of know is, do you have long segment or short segment? And that's really just based on how long an area, how far up the tube does it go, okay? If it goes up about 3 centimeters, which is just over an inch, there's 2.54 centimeters in an inch, if it's more than 3, you have long. If it's less than 3, you have short, okay? And then sometimes you can have these goblet cells in the upper part of the stomach, and that's called cardiointestinal metaplasia. And that's a condition that has an even lower risk of cancer than Barrett's does, and I'm not going to talk too much about that because that's much less common and it's also less risky. So again, you've seen this sort of slide before, and it's worth repetition because I think it's important to know. So you have the stomach, the folds come to an end, and then you have the tubular part of this food pipe here that's between the mouth and the stomach. That's the esophagus. And when you have this sort of gastric or appearing lining that sort of extends up into the tube, that's the region of suspected Barrett's. Again, you need a biopsy to confirm. So the 3 essential steps that you have to do is to sort of find out where sort of the end of the stomach is, and then recognize where the top of the pink area is and describe that length. And that's how you come up with a length for your Barrett's, and then you characterize it as short or long segment based on if it's more or less than 3 centimeters. So here's a patient who has a fairly long segment here. It goes all the way down here, and this whole area was more than 3 centimeters here, so this was long segment Barrett's. And then here's a patient who's got actually the stomach folds come up to here, so the real sort of lining of the stomach ends here, so there's only a little bit up here on this side. So this is a patient who has short segment Barrett's, okay? And the reason I mention this is that when we talk about risk, the longer the segment you have now, we know that there's a greater territory at risk, and so your risk of developing cancer is higher in longer segments. And we didn't really know the magnitude of that, but we now have a couple of papers that have sort of shown that there is increased risk with increasing length. Okay? So now one of the things that Dr. Roth and I are working hard to sort of bring to UCLA is this amazing new technology that allows you to sort of put a probe through the endoscope, and as we are doing this procedure, actually look at individual cells. Because right now what happens, for those of you who've had an endoscopy, you go in, the doctor takes some biopsies and says, well, you know, I saw something, I'll call you in a week, right? And then you start worrying about, well, what did he see? And then he doesn't call, and you're wondering, is that bad? You know, and so there's this sort of, you know, uncertainty and delay. This allows you to essentially look at cells and get a sense of what you're looking at almost immediately. It's essentially a microscope on the end of a probe. And this uses lasers, and it allows us to just going from detecting and suspecting to actually diagnosing. So this sort of allows us to sort of do something similar to what a biopsy forceps would do, okay? But at the time of the procedure. And the advantages, it allows us to better target our biopsies to areas that we think are really likely to be abnormal, potentially increase our ability to catch bad areas like cancer or early or pre-cancer, and allows us, if we're doing therapy of the kind that I'm showing you, I'm going to show you in a couple of moments, to make sure that we actually remove the lesion or have all of it. You know, one of the things you're going to, well, did you get it all? You know, well, we can sort of take this probe and run the margin of what we did and see if, you know, we actually think that we got it all right at the time of it, rather than waiting 3 months for it to heal and then bring you back and then find out, oh, it's back. We can sort of take care of it, hopefully, in a more precise way. Okay? But again, all this is still dependent upon a careful visual exam. So it's important that your doctor takes time to really carefully inspect the area, because you can't count on technology. Technology can't overcome poor technique. It can aid good technique, however. Okay? So again, the lining of the esophagus is kind of like your skin. It has these sort of fish-like scales, and these are some images from this probe. And then the lining of the Barrett'S is more of these gland-type areas here that you can see. And I'll show you some pictures. And then when you start getting into increasing levels of abnormality, the cells look more disordered, the glands look less clear, and then this just looks like a big mishmash. It looks like it went through the blender, and this, of course, unfortunately, is cancer, which, again, sort of shows that cancer sort of destroys architecture, and there's no controlled cell growth. Okay? So I'm just going to show you some representative images here. So this is actually real images here, so you can actually see individual cells. This is a patient with normal Barrett's. There's blood flow. Those are individual red blood cells that are actually circulating in your bloodstream right there. And so this is really remarkable technology, and it's something that we're hopeful to have here soon to help aid in sort of the management of patients with Barrett's and other conditions. Here's a patient with Barrett's esophagus here who's got, you know, again, formation of these glands. You see these sort of clusters here, and these are obviously a different kind of lining here. And you can see that even grossly you can kind of tell these two are not the same kind of thing. Okay? So the way that we manage sort of Barrett's is that we sort of sample the tissue once you have it, okay? Is we sort of diagnose it, you know, if we suspect it, you know, we sort of check and we take biopsies in all the regions here, and we sort of get an idea of what's going on at every level. It's kind of like floors on a building, okay? And we take biopsies, and so we get tissue, and based on, you know, what level of abnormality we think there may be, usually we take biopsies about every inch or so. We sort of go up and sort of take biopsies about every inch in the esophagus. Now, the current guidelines are that if you've got Barrett's, you should get these endoscopies done every year for 2 years, and that's basically to get enough sampling to make sure that we know that we have a pretty good idea of what's going on. And then after that, every 3 to 5 years, just take a relook, okay? For patients who have a little bit more abnormal tissue, we typically biopsy them more frequently, maybe every 6 to 12 months. And patients with particularly abnormal tissue, high grade, we usually recommend treatment. And I'll show you some of those treatment options, okay? And that includes treatment with endoscopic options or potentially surgical options as well, okay? So the question is, and this is really the problem, is who should get screened for Barrett's? What if I have heartburn and I don't know that I have Barrett's, but I wonder if I have it and should I get checked for it? And really, unfortunately, this is still a big area of uncertainty in medicine. We know that we think that patients who've had long-standing heartburn, more than 5 years, with multiple symptoms, episodes of heartburn multiple times a week, may be at increased risk. Maybe if there's a family history or if you have a large hiatal hernia with a lot of regurgitation. If you're in a particularly high-risk group, an older male, if you're Caucasian, that may be a risk factor. But the unsettling thing is that most patients who present with cancer didn't know, with this adenocarcinoma type cancer that Barrett's leads to, didn't know that they had Barrett's. So really the elephant in the room is that while we know about the 10 or 15% of patients who have the cancer while they know or known to have Barrett's, 85% of people just show up with the cancer and they never knew they had Barrett's. So how do we find these people? And if you say, well, let's just scope all the people who have reflux, we'll find them that way. Turns out that doesn't work very well. So we're working on new techniques that your primary care doctor, there's one that involves a sponge that you'd swallow and you'd look for certain biomarkers, and if it's positive, you'd get that would recommend you for a scope test. So this is really probably the major area in Barrett's right now, is to figure out how to capture the people and identify the people who are most at risk. And unfortunately, despite our hope, reflex alone is not going to get it done. Okay, so a history of that. So what does having Barrett's put you at risk for? Well, I've sort of alluded to it several times. It's esophageal cancer, as Dr. Muthusamy was talking about. And in the United States, worldwide, there's about 500,000 people who get esophageal cancer, and it's one of the worst cancers to get because it tends to spread early. It gets diagnosed somewhat later. And if you take a look at the 5-year survival rate, it's not nearly as good as some other cancers that we have. And it's quite frequent. But if it turns out, if you look worldwide, most people have something called squamous cell cancer that's associated more with tobacco and alcohol use, and very few people actually have this adenocarcinoma. And if you take a look at the distribution, it's quite interesting. Most of the squamous cancer occurs sort of in Asia, the Middle East, and parts of Africa. But if you take a look at adenocarcinoma, which is what Barrett's can turn into, it's really a disease of more of the Western world or more industrialized countries. So you see it in Australia, you see it in Europe, you see it in North America, okay? So it's really almost like the sort of risk of, developing the cancer is dependent upon where you live in the world. And we think this is because of increased reflux, increased obesity, so forth. You live a more sedentary lifestyle in the more industrialized countries, and that's been proposed. And you can see that the cancer rates are actually going up significantly higher. You can see the risk of esophageal adenocarcinoma is going up about 20% per year in the United States, and that's partly because of the obesity issue, and also because a lot of people are getting detected because we do a lot of endoscopy in the United States. And if you take a look at how fast esophageal cancer adenocarcinoma is growing, in GI we've made progress with colon cancer, and you can see the colon cancer rates are actually dropping for the rate of death related to, and development of cancer, is actually dropping, whereas the number of people who are getting diagnosed with esophageal cancer is skyrocketing compared to all these other types of cancers. So I kind of alluded to this earlier, but essentially the sort of cycle is sort of you go from chronic reflux leads to the development of Barrett's, and then Barrett's can sort of over time progress to low grade, high grade, or even cancer by an accumulation of abnormal genetic changes. And so the question is, really the other big question is, how do you predict if you've got Barrett's, whether you're going to be somebody who moves down this chain or if you're going to stay at Barrett's, And what are the factors? And there's a lot of proposed factors, but we don't have clear factors to predict who's going to progress and who's not. So at present, we sort of follow everybody. And that's what those biopsies are done for every so often, is to see where you're at and how you're doing. So the next question is, okay, so what is your risk of progression if you have different steps? So I'm going to start sort of with high grade, then talk about low grade, and then talk about Barrett's. So if you're at high grade, you can imagine this as sort of a color scheme. If normal was white and black was cancer, we're going to work our way through shades of gray, okay? So you could say that high grade is a very dark gray. It's almost black, okay? And so these people are at high risk for cancer, between 6 and 10% per year. And if you take a look at all the different studies and analyze them together, you see that it may be on average about 7% per year, which means that if you're a 50-year-old with high-grade dysplasia, the fact of the matter is you're probably going to get cancer in the next 10 years. And so for that reason, in 2012, we don't watch high grade. We don't sit there and biopsy it. We act. And that we have endoscopic treatments. We have surgical treatments, okay? But we would do one of those two things, okay? In patients with low-grade dysplasia, the numbers are a little bit different. It's almost like, is coffee good for you or is coffee bad for you? You know, you hear a different study, different day. So some studies suggest low-grade is very risky. Some studies say it's not that risky. Part of the problem is that low-grade dysplasia, okay, is something that can occur when you have a little bit of inflammation. So if you've got Barrett's and your heartburn's not under control and your doctor finds that you've got some inflammation on your endoscopy, that can make the tissue look angrier than it actually is. And so when you take a biopsy and show it to the pathologist doesn't necessarily know how inflamed it looked to the endoscopist. They just have to see what they say under the microscope. And so they're going to err on the side of caution and say, well, you know, this looks kind of abnormal. I'm going to call this low grade. But it turns out that when you sort of accurately assess patients with inflammation, it turns out that most low grade is just inflamed Barrett's. And so low grade, true low grade probably is a pretty risky lesion, but there's a lot of people who have false low grade, you could say, which is just inflammation. So this is actually where you need an expert pathologist and you need a team approach like we have in the Esophageal Center here at UCLA to really sort of work around these issues and figure out what are we really dealing with here, okay? For non-dysplastic Barrett's, the risk is low and maybe even lower than we thought, okay? So the risk, this is just a whole bunch of studies and it's a busy slide, but basically the cliff notes here is the risk of cancer for non-dysplastic Barrett's is only about 0.5% per year, which means that in a 10-year period, you've probably got a 5% chance of getting cancer, which means you have a 95% chance of not. Now, 2 large European studies have suggested it's not even that high, that it may be only a third of that. And so there was a study that was done in Denmark that it was only 0.12%, and one in Ireland that was 0.13%, which means that a 10-year risk was only like 1.3% total. So these are very small sort of risks that are present, okay? So the next thing is, how do I treat it? The fortunate thing is that we actually now have treatments for Barrett's esophagus that are quite effective, and that was not the case 10 years ago. And it's not a question of if we should, you know, can we treat it? It's who should we treat it on, okay? So you can obviously try to keep the inflammation under control by anti-reflux medications. We do surveillance biopsies to watch people to see if they're progressing. But the problem is that that's a lot of endoscopies. People don't like it because they feel like they're just waiting for something bad to happen. It only detects, it doesn't prevent cancer. And when you take these biopsies, you're sampling straws from a haystack, but you're not getting all the straws. So you only sample about 3 in every 100 straws, or 5 in every 100 straws based on surface area. And they've actually been computer models looking at this. And it turns out your doctor may not take the appropriate number of recommended biopsies. So in fact, I'll show you some data. And there's no clear study showing that even though it seems like a good idea to keep a close eye on it, there's no data that shows that this actually works in preventing cancer. And in fact, as this goes back to the point that I told you, the majority of patients who show up with cancer didn't know they had Barrett's in the first place. And that's part of the big problem that we have is how do we find these people before they show up with cancer? So here's the studies that I was showing you about, but this was a study in the Netherlands that showed that the shorter the segment you had, the more likely your doctor was going to take the biopsies the right way. But the longer you got, the less they sort of adhered to it because they took fewer than the recommended number. So 80% of the time they did what they were supposed to when it was shorter, but when it got to very long segments, they only did it about a third of the time. So even if they did everything the way they were supposed to, you'd only be sampling about 5%. So if you have abnormal tissue, again, you can do this, you remove the tissue with snare. This is basically a way for us to do a mini surgical resection, okay? We lift the tissue and we actually lasso it and cut it off and take the whole specimen in a piece and send it to the lab for analysis, okay? And there's a variety of ways we can lift it and put a lasso and cauterize it. We can suck it up in a clear tube and then put a lasso around the base and cauterize it. Or we can put a rubber band around it and then cut it at the base. So it's sort of the same concept. Get it to lift and then cut it off at the base. And this, you get a nice piece of tissue which can aid in both the diagnosis, but it can also be therapeutic, because if the entire area of abnormality is within this with clear margins, we may be okay, particularly for things like high-grade or very, very early cancers. So here's an example of a patient who had Barrett's with high-grade dysplasia that came to me, and there was an area of high-grade in this area here, and we did a very large resection here. It looks like you'd taken a divot out of the golf course here. So you have this area, and this will heal up over approximately 6 to 8 weeks, and then we come back and we'll re-biopsy this area and make sure that we have everything, okay? So this is one resection technique, and this tends to go somewhat deeper. But really for Barrett's, again, Barrett's only involves the lining typically, and so the goal would be to just remove maybe only this much, and that's where ablation therapies come in. The advantage of ablation is that it doesn't go very deep, and it ultimately kills the cells, but the disadvantage is that it's ablation, it's not resection, which means that I kill it, but I don't collect it, okay? So I don't know. You sort of spray it, and it's like spraying, weed killer on your lawn. You don't know what that was that you just killed, but you hope it's gone, So, and that's essentially the same concept. You don't have, and you come back and you just see what grows back, and you hope it looks normal. So you can do it, again, for ablation of the esophagus, you can either cool it or heat it, and we have both techniques here at UCLA. The heating technique is the one that's sort of got much more literature on it, and I've been involved with that for 8 years. In doing a lot of that work. And it's useful for both treating, it can be used in all stages of Barrett's, but probably is most useful in treating the high-grade patients and the low-grade patients, okay? Ablation doesn't usually go very deep, so it's not appropriate to treat bumps or lumps, and it's not appropriate really for cancer. Those are best managed with other techniques or surgery. So again, there's two different kinds of treatments here. Again, there's a heating technique, which comes with sort of this balloon, which kind of goes down the esophagus, which I'll show you, and sort of burns off 3 centimeters of Barrett's at a time. And it has this little probe, and not everyone has the same size food tube here. So as a result, we first have to use a sizing balloon to sample, to figure out the size of the esophagus, and then we do the treatment with this catheter. Sometimes if you only have a little bit, or maybe it takes a couple of sessions to get rid of all your Barrett's, we have this little thing that looks like an extended fingernail, and we just use that to sort of touch up the edges, okay, of areas that are rather small. So here's a patient with a region of Barrett's from here. So we first come down, we size the esophagus, figure out what size balloon we want. Then we bring in the real balloon, we inflate it, we burn it, we deflate it, inflate it again, burn it, pull it out, scrape off the dead tissue, repeat times 1. Okay, and that's it. Then we give you a few months to heal, and we come back and see what's left, and then do any touch-up at that point. And so here's what it looks like. Here's a patient with Barrett's, and then here's what the tissue looks like. It's just like if you skinned your arm when you fell on a sidewalk or something. You take off that surface, and then you let it heal. And the amazing thing is, if you heal in a non-acid environment, it will grow back as squamous tissue. If you heal in an acid environment, it will often go back as Barrett's. So this is one of the times when you say, Doc, how can I help you? Well, you can help us by taking your medications and taking them the way Bennett told you to, because otherwise, okay? And again, I'm going to sort of, this is, there's the focal device there as well. And again, I told you about the Barrett's here. You've got, again, the goal is to take the surface off but not get too deep. That gives you the advantage of being able to successfully eradicate this. So again, here's a patient with Barrett's before. Here's one sort of how it looks like after. And this has been published in many of the top journals, including the New England Journal of Medicine. This was a study that I participated in that looked at patients with Barrett's who had high-grade dysplasia and low-grade, like we talked about. And there was a total of approximately 123 patients, of which 2/3 got treated with the ablation and 1/3 got watched for a year. And then the people who got watched then got ablated in year 2. And so this is just a little diagram sort of showing how that went in the paper. So when you take a look at the people based on which group they were sort of put in, if you got treated with this device, you got rid of all your Barrett's 77% of the time if you were put in that group. And you could get rid of all your low-grade dysplasia 91% of the time, and 81% of the time you got rid of all your high-grade, and obviously much less if you didn't get treated, okay? when you look at this thing called per protocol, which basically means not just which group you were assigned to, but whether you actually got treated. Sometimes people fall out because they got sick or they changed their mind. The numbers are better. So 83% of the Barrett's was eliminated and about 90 to 95% of all the dysplasia. And then when you take a look at how many people would you need to treat to avoid developing a cancer, you know, every 12 people with dysplasia we treated in this study resulted in the potential for avoiding cancer in one patient. Okay? Again, these are patients who had dysplasia, either low grade or high grade. So here's a video to kind of show you sort of the before and after. So here's a patient who's got this is the stomach. We're looking at, there's a bit of a hernia there. There's the end of the folds, and you're going to see some Barrett's type tissue. There's the end of the folds of the stomach. So we're at the junction of the stomach here. We're going to come back up. We're going to pull up, pull up, pull up. And then actually the Barrett's goes all the way up to here. I hope you can see that difference in lining between there and here. So this is a fairly long segment of Barrett's. So 7 centimeters. I told you 3 or more is long, okay? Here's that same patient after one treatment. Now, this isn't typical, but obviously I'm going to show you some of our best results here. But this is a patient in one session who got rid of everything in one shot. I didn't have to do any touch-up. So that happens rarely in someone this long, but it's routine to get rid of all the Barrett's in 2 to 3 sessions usually in most patients, okay? So this just sort of shows you the pre and post treatment here, and this patient did very well. Okay, so this is just a busy slide telling you that there's a lot of studies that have looked at this, and the ability to do this successfully is very high. 90 to 100% success for getting rid of the dysplasia, and probably somewhere in the range of 85 to 90% success in getting rid of all the Barrett's. Okay? And this works long term in people followed 2 to 3 years. The ability to keep the Barrett's away is over 90%, and the safety is quite good in terms of these. Occasionally you may get a little narrowing, a stricture which we dilate with a balloon, but that only occurs in less than probably 1 in 10, 1 in 15 people. Overall, the safety data, this has been done now, actually this is a little bit old, it's now been done over 100,000 times in the US, so this is not experimental, okay? And if you take a look at the rate of stricture and perforation, it's quite low. It's probably about as safe in terms of getting a perforation or some problem, similar to you getting a colonoscopy for screening purposes, which many of you probably have done already, okay? So very, very safe at this point. I'm going to briefly talk about cryoablation in the last 5 minutes here. This is a freeze technique that basically can use nitrogen or carbon dioxide gas, and rather than burn it, you actually cool it, and then you kill the tissue by causing ice to develop in the cells, and then the freezing and thawing kills the cells. And so that's the mechanism of action, is you freeze it, you thaw it, and then sort of the tissue sloughs off and heals, okay? And I'll show you a picture. Here's an example of what it looks like. We're spraying, and then sort of this thing will turn sort of cool, and then it'll turn in this white color here, and then the white will sort of thaw, and then we'll freeze it again, and we usually do that about 3 times, and then we stop and we let it heal, okay? So this is something we also have available to us. We use cryo in people who have nodules, or it goes a little deeper than the RF. So the RF is for only surface, but this can actually go a little deeper. So they work nicely in complement with each other, okay? And this is a patient who had cancer who had a good treatment with this effect and actually had an early cancer that we treated. So in the last couple of minutes here, I'm going to just kind of go over a little summary then. This is just a little bit of data showing how effective this works, and this also works about 70 or 80% of the time. So the last sort of couple of minutes I'm going to talk about is who needs to be treated, and there are several guidelines on this, and I'm just going to summarize those guidelines. So in patients with high-grade dysplasia, basically you should get treated, and that could be through the endoscopic techniques I talked about, but they require repeated follow-up long-term, or Dr. Lee's going to speak next about surgical options. And of course, that's something that doesn't require the same intensity of follow-up as the ablation does. And the surgical societies also agree with this, okay? In patients with low-grade dysplasia, we believe that in patients who have true low-grade, not just inflammation, but true low-grade, it's a reasonable lesion to treat because the risk of progression to cancer is anywhere between 2 and 4% based on the studies, and some studies as high as 8 or 10% when it's confirmed, okay? But the big thing is, what if I don't have dysplasia? I just have non-dysplastic. I've sort of outlined some of the issues that are here. You don't sample all the tissue. It seems very passive. Physicians don't necessarily take all the biopsies. But on the other hand, you also don't have very much in the way of a risk, because the risk is only between 0.5 and 0.1% a year. So it's reasonable to continue following it unless you're really anxious about it for some reason, or you have certain high-risk factors, which are usually considered to be family history, young age, or a very long segment. And in those cases, it might be reasonable for you to be considered for ablation. Okay? And that's, in fact, exactly what the American Gastroenterology Association has suggested is surveillance is quite reasonable, but select high-risk patients might be a candidate for ablation. Okay? And I've sort of just gone over who's at high risk. So in summary, Barrett's is a common condition. Most patients won't proceed to cancer because if you're non-dysplastic Barrett's, your risk is very low. We do have options to ablate the tissue, either freezing or burning, in patients who are at dysplasia or high risk or very anxious. But we need better tests to figure out who's got Barrett's, because still most patients are presenting with cancer, and we need to do a better job of identifying them early. Thanks for your attention.